Thank you, Dr. Prabha. Good morning, everyone. On behalf of all of you here and University College of Medical Sciences, I welcome Dr. Meru Sheel and thank her for accepting our invitation to come and deliver a talk on an issue. All of you who are from public health background and also from different fields in medical sciences, you will appreciate that epidemiologically we are at the transition stage where the non-communicable diseases have started becoming a predominant force in the morbidity world, but at the same time, we have not been able to get rid of the communicable diseases at present. So this transition has become very prolonged. And in between we are seeing not only the pandemic of COVID, but other than that, time and again, we hear about occurrence of different infectious diseases which threaten to become pandemic. You'll be able to appreciate that there were outbreaks of Nipah virus reported from Kerala, and very recently there was a report of one death happening in West Bengal. Similarly, Crimean Congo hemorrhagic fever, that's another condition. Then we have the Kaisanur forest disease, which is expanding. Expanding means which was restricted to the Kaisanur forest disease has now grown into covering 4 different adjacent states. And besides that, many other sporadic outbreaks of infectious diseases continue to happen across the country. And with the Integrated Disease Surveillance Program, the IHIP, is repeatedly giving data on outbreaks in different parts of the country. And under the One Health umbrella, we have started talking about the potential risk of several zoonotic diseases which are threatening the human population. So that means we are not really cannot become complacent with the fact that with development, with growth, and with urbanization, the disease paradigm has shifted to non-communicable diseases. No. Now we are in the state of double burden. The non-communicable diseases is now being added to the existing problem of communicable disease which we have not been able to control. And today, just before coming here, Dr. Ranga, our head of the department medicine, pointed out that he found a relationship between atherosclerosis and tuberculosis. So this compartmentalization of non-communicable and communicable disease also is questionable, because every communicable disease may have a non-communicable component to it. And non-communicable diseases either may be a consequence of an infectious disease or may result into increasing the risk for an infectious disease. So probably the joint approach to looking at the issue of diseases that are intertwined and always threaten the health of the human population in particular, we need to have a fresh outlook. And with that background, we are fortunate that someone with a huge experience in the field of infectious disease, pandemic, vaccinology, and working across different countries in the Asia-Pacific region will be sharing her experiences with the group today. So once again, welcome to you, and we eagerly wait to hear from you.
Thank you, sir, for your warm welcome and encouraging words. As a token of our respect and appreciation, we would now like to felicitate our esteemed guest speaker, Dr. Meru Sheel, ma'am. May I request our respected principal, sir, Dr. Dheeraj Shah, sir, Dr. Arun Kumar Sharma, sir, and Dr. Satendra Singh, sir, Member Secretary of the International Academic and Research Collaboration Cell, to kindly come forward for the felicitation. I request Dr. Lopamutra, second year PG resident, Community Medicine, to bring forward the memento for felicitation. Thank you, sir. Thank you, ma'am. I now request our respected principal, sir, to kindly share the introductory remarks and formally introduce our distinguished guest speaker.
So it gives me immense pleasure to welcome you all. First of all, our distinguished guest speaker, Professor Meru Sheel, Dr. Arun, Professor Arun Kumar Sharma, Dr. Satendra, the Department of Community Medicine, and all our dear resident students. This topic, pandemic preparedness, has become so important that it has at a very fast pace, it has moved from our textbooks to real life. We have seen during COVID, before COVID, we just were reading about these in textbooks, 1918 influenza epidemic, then our own repeated plague epidemics, and then few other pandemics we used to read in textbooks. But then suddenly COVID-19 was there, and it made us realize that viruses do not need any visa, they do not need any passport, they do not need any tickets, they just travel by road, by air, by water, by whatever means possible, and then they do it very fast. They do it very efficiently, unfortunately, and not only viruses, and then we talk of pandemics of bacterial infections, then we talk of pandemics of non-communicable diseases like obesity, pandemic of HIV, and then pandemic of atherosclerosis. And then we also know that there is a link between these two, as we know that for Takayasu arthritis also we had this hypothesis and very well, I would say, established fact that tuberculosis is a major cause of Takayasu arthritis, which is an inflammation. Then it similarly, definitely it could be a cause of inflammation in the coronary arteries as well. So as Dr. Arun Sharma said that the diseases do not see global boundaries, कि यहाँ पर इंडिया है, यहाँ पर पाकिस्तान है, यहाँ पर चाइना है, वो कहीं से कहीं जा सकते हैं, और वो भी ये भी नहीं देखते कि मुझे इन्फेक्शियस डिजीज़ करना है या नॉन इन्फेक्शियस डिजीज़ करना है, वो अपना काम करते रहेंगे. सो आर रिस्पॉन्स हैज़ टू बी कोलेबोरेटिव. जैसे कि उनका रिस्पॉन्स कोलेबोरेटिव है, उन्हें अपना काम करना है, इन्फ्लेमेशन करना है, उससे कुछ भी हो, ऐसे ही हमारा काम भी है, हमें उनसे रोकथाम करनी है, हमें अपने आप को बचाना है, अपने सिस्टम्स को बचाना है. सो वी ऑल्सो हैव टू वर्क इन कोलेबोरेशन, चाहे वो हॉस्पिटल्स हों, चाहे लेबोरेटरीज हों, चाहे वो पब्लिक हेल्थ सिस्टम्स हों, चाहे कम्युनिटीज़ हों. वी हैव टू वर्क हैंड इन हैंड, एंड वी हैव टू वर्क लाइक ए स्ट्रॉन्ग चेन. जो स्ट्रॉन्ग चेन होती है, जंजीर होती है, उसकी एक भी कड़ी कमज़ोर हो तो उतनी ही स्ट्रॉन्ग चेन होती है. स्ट्रेंथ ऑफ अ चेन लाइज इन द स्ट्रेंथ ऑफ द वीकेस्ट लिंक. तो कहीं पर भी वो लिंक वीक होगा तो वो जंजीर टूट जाएगी. तो उस जंजीर को मजबूत बनाने के लिए हम सबको मिलकर काम करना है. और काम कैसे करेंगे, हमें ये नहीं करना. यस, आवर कंट्री हैज़ डन वंडरफुल जॉब ड्यूरिंग कोविड-19. इट हैज़ established the diagnostic network very fast, the diagnostic networks of VRDLs established. जब हम पहले सोचते थे कि हमारे देश में RT-PCR का टेस्ट इतनी बड़े लेवल पे होगा भी कैसे, लेकिन छोटे ही टाइम में हमने कर दिखाया. हमने सोचा कि इतने बड़े स्केल पर हम वैक्सीनेशन कैसे कर सकते हैं, वो हमने कर दिखाया. So we have shown to the world, but definitely we should also learn from the world. So it is always good to see the best practices. We have done wonderfully well in some aspects, but we must have not done as well in some of the aspects, and the other countries might have done well in the other aspects. So it is always good to learn, and what better to learn from our distinguished speaker, Meru Sheel ji, who has worked in various countries, especially in the South Asia, Southeast Asia, Pacific. I was just listening to her. She has worked in Laos, Papua New Guinea, Indonesia, and many other countries, and they have also done good to fight various pandemics, especially dengue, sometimes COVID-19, and learning from the best practices is one of the methods of learning, teaching learning. So we welcome Madam, and thank you Department of Community Medicine for bringing her to UCMS. Thank you so much.
Thank you very much, sir, for your insightful remarks and for introducing our esteemed speaker. Without further delay, it's my privilege to invite Dr. Meru Sheel ma'am to kindly deliver today's guest lecture.
Thank you, everybody, for this warm welcome, and Professor Sharma, Professor Shout, for the invitation to present today. My name's Meru. I am a vaccine researcher and an epidemiologist, and I work on a range of different diseases. My main interest is in epidemic-prone diseases and really understanding how we strengthen health systems to prepare better for outbreak-prone diseases. I lead a small research group called the Infectious Diseases, Immunization and Emergencies Research Group at the School of Public Health at the University of Sydney. We have team members who, one of them is from India, one from Indonesia, one from the UK, one from China, lots of diverse members. And today I'm not talking just about my research projects. I won't tell you about all of their work. I'm talking about a broader topic. And I was listening to one of your colleagues this morning about how pandemic preparedness is now a mandatory course in your undergraduate teaching. So I'll keep that in my mind as we talk today about what are the opportunities, what are the intersections. The talk I've put together today is a bit more high level at a policy level, talking about the tools and the ideas that are coming, because all of you know about the local responses much more than I do. So I've tried to just curate a set of slides from different parts of the thing. I will start a little bit from like what has, we think about pandemic as just COVID-19, and that's not true, because what is the history of pandemics and epidemics? I'll then talk a little bit about COVID-19 pandemic and what we saw differently, and just try to bring in examples and thinking of what was working well and what wasn't working well. Because I do think the COVID-19 pandemic challenged us in many ways to think differently, to act with agility. The scale was unprecedented, and I think that's why everyone thinks about COVID as the ultimate pandemic, because before that was the influenza, Spanish flu epidemic in 1918, but that was such a long time ago, most of us weren't alive at that time, that it's hard for us to imagine. Whereas now with global connectedness, it's obviously the scale is much bigger. And then I just want to highlight a few post-pandemic developments and future considerations. And I think this is where there'll be opportunity. I'd love to hear from all of you of where you think priorities are, where India's role is, where your local community role is. I know a lot of you study community medicine, but also come from infectious diseases, microbiology, pediatrics. And I hope at the end that you'll see that every person through the field of medicine and health is bringing a unique lens and a consideration towards how we respond to outbreaks, to epidemics and pandemics. So that's really my goal today, is just to plug in some ideas, some things. So it's going to be random set of examples. It's not going to be a proper scientific presentation in your traditional format, but just ideas from around different places so we can have a discussion. And I would love to hear from everybody at the end of the session with lots of good and bad questions, as we say. So I thought I will start with this basic slide, because often, and I think it relates to that point, that why are people suddenly not interested in pandemics, or why is there a fatigue? And even my own journey, it's a funny story, because I originally trained as a vaccine scientist and an immunologist, and then I moved into public health as an epidemiologist and wanted to work in emergencies and immunization and the intersection of it. But before the COVID-19 pandemic, even I would often hear from people of who cares about emergencies or outbreak research. But people forget that that little outbreak is what makes a pandemic, because we often deal with three concepts of a disease outbreak, which is often a small cluster, or in the context of, I guess, when we think about a restricted area. An epidemic is something that's a sudden increase of cases through a larger population group. So you can see over here in the middle, everyone knows about endemic diseases. Those are diseases that are constantly present. So TB, HIV, those are endemic diseases. Not to say that they cannot have a sharp rise. Endemic diseases can also lead to outbreaks. Measles can lead to outbreaks. But epidemics are, I guess, sudden increase. And then a pandemic is just a sudden increase across several countries and continents. And I want to show some ideas and plug this idea later on. I'll show some work that we're trying to do on measles at the moment, really with this idea that, you can work at a local geography. And if you don't, you can control an outbreak and an epidemic before it becomes a pandemic. really. And of course, there are some pathogens that have greater pandemic potential compared to something like, say, Nipah virus, as Prof. Sharma was alluding to earlier, which is a high fatality pathogen. I'm not talking about Nipah today, but one of the reasons why it's a challenge is because it is a high fatality pathogen, but it's unlikely. So suddenly, because pandemics have become so this thing, when the Nipah virus outbreak happened in West Bengal, we had the Australian health minister made a statement, media was all over it, everyone was panicked. And all of us are saying the risk assessment is low, it's unlikely that Nipah will become a pandemic. Yes, it might become a larger outbreak, it might become an epidemic in certain parts of the country, but as long as there's early intervention and public health responses, it will likely get managed, which is what has happened. But it's unlikely that it'll become a pandemic because the person-to-person transmission is not as sustained compared to, say, like the COVID-19 pandemic where there was sustained transmission. So as I was talking, I thought, it's often also important for us to think about not just the pandemic as an infectious disease outbreak. And I think this is the point that people miss often, that we need to think about, is why does a pandemic matter? Of course, there's a direct impact. There's a high morbidity and mortality burden often in a very acute period of time. And if you let that burn, say Nipah or COVID-19, if you did nothing, it will lead to a high mortality and morbidity in a very small amount of time, which is different to how, say, TB might spread. And I think that's where people get confused, not to say that those diseases don't matter or one is important than the other. It's just the time and the speed with which an infection spreads, and respiratory pathogens particularly have that. I think we also have to think about, what impact it has on essential health services and disruption to other programs, which all of you would have seen in terms of mental health, in terms of NCD screening. We saw all of these service disruptions in terms of economic impact on populations, societal impact. And I thought, having a photo of this particular movie, some of you may have already watched it, it's a really beautiful depiction of how people were impacted by large mass closures of the pandemic, particularly in countries like India. In countries like Australia, implementing a lockdown had severe impact on people's health. Some of you might have heard about how Melbourne had the longest lockdown in the world. Their second lockdown was 110 days or something like that, and a very strict lockdown. Friends of mine were so depressed, and mental health for people and children in Melbourne still have PTSD from that time of being locked down. And Australia has a very good social support system and a social security system. People were getting, supplementary income from the government to stay at home. If they had these schemes called jobs keepers and seekers to support that. But that's not feasible in all countries. It's particularly challenging in low and middle income countries where there are a lot more larger economic constraints or distances and populations. There's a lot more casual economy, so people rely on daily wages, etc. So I thought that was a really good depiction in this movie. And I thought it makes sense to then talk about what are some of the famous pandemics, so to say. And I found this really nice slide. Now, it's really small, and I'm hoping that if I move, people online can still hear me and see me, but it's a really nice slide from Our World in Data, which is a really good data analysis platform. There's a person who curates all of these data sources, and I'm going to see. I won't bother with this, but essentially what you can see in this timeline over here is they talk about the first cholera pandemic. So pandemic since 19th century, 1800s. Cholera is some of the early stuff that we see, and we know cholera still causes. Every time there is a cholera outbreak or an epidemic, there is quite a significant morbidity and mortality. Many parts of the world, Bangladesh particularly, when I worked on Rohingya crisis in Cox's Bazar, they were able to prevent major cholera epidemics because they did early OCV, oral cholera vaccine campaigns. But that was one of the biggest scare factor because of poor water sanitation and hygiene. And when you have endemic pathogens, it can, and that happens in India as well, you will occasionally see. The most famous one that some of you might know about was in Haiti. After the earthquake, they had a very large cholera epidemic that took years and years and years to control because the infrastructure breakdown was so bad. And it wasn't endemic to Haiti. It was a pathogen that came with some of the troops, military troops who came to as part of earthquake response, but then it seeded new cases as well. So cholera is an obvious one. And then you can see over here Spanish flu in 1918 to 1920, and this is, it's estimated to have caused 50 to 100 million deaths. We had the Hong Kong flu pandemic, 2 million deaths in 1960s, and then in 2000s you've had, in the 80s we had the HIV/AIDS epidemic, which is voluntarily, you could say it's a pandemic because it crossed so many boundaries. SARS epidemic, we thought this was going to be bigger, but it ended up being smaller and got contained. And I think that's why people were confused about the COVID-19 pandemic, because it is COVID is caused by a SARS virus, and people thought it'll be like that SARS epidemic in the early 2000s and it will burn off on its own, but it didn't. Swine flu in 2009. And then we've got the MERS epidemic. We see clusters of MERS appear in many parts of the world. They've had, obviously in the Middle Eastern region, they have MERS cases, but also in Japan, there's been an outbreak of MERS, which is a Middle Eastern respiratory syndrome disease. And then you have the COVID-19 pandemic. And of course, let's not forget things like Ebola virus disease, which again, has potential, is an epidemic, is a very big epidemic disease. And while we haven't seen it get spread to many parts of the world, it is very much a pandemic potential virus. We know what it did in the 2014 outbreak in West Africa, spread across Africa, but once it's exploded, because again, the transmission is so easy through body fluids, it's a high-risk pathogen and high fatality. But I want to now come to the COVID-19 pandemic and talk about some pandemic aspects, really. And so I guess I like to always start a COVID-19 or pandemic talk with this particular talk. And I think this is the core of pandemic preparedness that we have learned over the years, that to deal with a pandemic, we have to think in a multi-sectoral way. And I'll talk about the idea of One Health later on, which things like Japanese encephalitis, which again is endemic to parts of India, but India's done really well with the state-based vaccine program for Japanese encephalitis, but also things like Nipah virus outbreaks, Kaya-Sanur disease, all of these things are One Health approaches. And again, and the reason I also pull this slide up is because often many of us who are trained from a biomedical side or a medicine side, we think about diseases from a biological, physiological way. And it's not to say that that's not important, but I think we all need to shift our thinking that public health is a lot more than just the medicine side of things. And it requires this multi-sectoral approach, because to get something into a clinic, for example, to do a lab diagnostic, as we were talking, one of your colleagues was mentioning about the new surveillance project. It's okay to have the surveillance guidelines, but actually there's a lot of thinking around how is this going to work? What will happen when a patient presents? How are you going to collect the sample? And then how will that sample get to where it needs to get tested? How will the data? So all of that is interconnected. And we shouldn't even forget things like operations and logistics. All of those things are really important. Now, somebody who's medically trained may choose to work in operations, but they may not choose, and that's the point I want to make through this. So that's why I always like to start with this, because I think many people have had this blind spot in our training programs all over the world, in our guidelines when we write about pandemic guidelines. And traditionally, this is all guided by three main things that I would have said pre-pandemic is how we look at it. The International Health Regulations of 2005. This is obviously a key global instrument that is endorsed by all the member states of the world on, I guess, providing a legal framework on how diseases that need to be notified or epidemic-prone diseases should be managed, and what are the legal obligations of all countries. What we do also know is that the IHR wasn't as legally binding as it should have been, because it was an instrument with not really rights. So lots of countries didn't really do what was expected to be done in the pandemic, and border controls came in, and countries got placed with inappropriate bans and travel bans, all kinds of things in the pandemic that weren't necessarily aligned with the IHR And those are the experiences of the pandemic that has led to the revision of the IHR, and I'll briefly talk about the pandemic agreement later on. The second key document, for those of you who are interested in emergency responses and from the public health side, this is a key document, guidance document that people should be familiar with, called the Emergency Response Framework. And it really guides you on to what are the different elements that need to be put in place for any kind of outbreak response, but also a natural disaster response, if it's a cyclone or an earthquake. And there are colleagues who mentioned that they have an interest in disaster risk reduction and disaster responses. From a health perspective, the emergency response framework is what we always consider when you're working on that, or what are the different domains that need to come in. And then the other document that I wanted to mention was this thing called the Asia-Pacific Strategy for Emerging Diseases, which has now been replaced. But pre-pandemic, this is what we had. And this was the key strategy that brought together the Asia-Pacific region from a WHO perspective. It was called the APSED. It's now been replaced by the Asia-Pacific Health Security Action Framework. It has a very complex name, but if you look it up, you'll find the new document that has replaced it. But I would say in our region of the Asia Pacific, and this particular document was, because some of you might know that the WHO divides the Asia Pacific region into the CRO region, so Southeast Asia Regional Office, and the WIPRO region, the Western Pacific Regional Office. And those are partly political boundaries, partly management bodies, because obviously no one office can cover all of that. But this document really cut across that. If you think about our region is connected, Indonesia used to be part of the CRO region. It's now moved to the Western Pacific region. But really, as Principal Sir said, the boundaries have become arbitrary. We really cannot think about infectious disease outbreaks as contained to certain countries, et cetera, as well. And so this is a photo I wanted to share an example and story of in some small countries in 2020, early 2020. I had the opportunity to go to Tonga, which is a very small Pacific island country of 100,000 people. That's the total population, 100,000 people. So very small compared to, I mean, even your local catchment area would be larger than that, right? But they were having a measles outbreak, and it's a very interesting outbreak because it started off in the Philippines. Philippines was having this large outbreak of measles for many years in 2018-19, and it was related to the fact that they had the rollout of the dengue vaccine, which had to be recalled, and they were seeing all these deaths from after the dengue vaccine. This was the historical dengue vaccine. And that inappropriate or terrible rollout that happened, and deaths in people who were vaccinated because the cross-reactivity wasn't known until then, led to a breakdown in their confidence of their routine immunization program. So their measles vaccination dropped, and that led to a large epidemic. Somebody traveled from the Philippines to New Zealand. New Zealand had a weak routine immunization program and gaps, led to an epidemic in New Zealand. Pacific Islanders travel a lot to New Zealand, back and forth. And the national rugby team of children, the sports team, went to New Zealand for a game, and some of their teenage boys got exposed to measles. And they did not declare their symptoms on time, and they hid at night and jumped hostel windows and exposed the whole country, and they ended up with a large outbreak. So it's a fascinating story of how quickly things can move unknowingly, unconsciously. You know, these were young children who were there to play a rugby game, and they got exposed. So I was in Tonga to respond to the measles outbreak, and a day later, on the 23rd of March, I got a call from the WHO office, and they said, we need you to set up the COVID-19 preparedness plan in Tonga. And none of us knew at the time. We were calling it novel coronavirus disease, if some of you will remember the name, NCOV. And so this was the first morning when we brought everyone together. So we've got the director of public health, a junior registrar at the time, environmental officer, the chief nurse, one of the other clinicians, the assistant secretary, the chief medical officer, and me. And so you can see the whole team coming together. Small country, single person. But this was their whole public health response to start planning a multi-sectoral response to COVID-19. And these teams here, the environmental health, were really at the points of entry. setting up screening at the airports, because Tonga being an island, most of the people come in through the airport way, some through the seas, but mostly at the airport screening way. So just want to share that example. But I want to sort of talk about prevention and control measures, and this will be more in the realm of what, when we talk about the pandemic now, when I look back, we often, now we define it in three main categories, I would say, from a prevention and control measures perspective. The first is the non-pharmaceutical interventions. So really thinking about social distancing, hand hygiene, masks, lockdowns, etc. Public health response, which is where I would put surveillance and contact tracing. That's what I would call core public health response. And pharmaceutical interventions, which includes treatments and vaccines. And today I'll only talk briefly about vaccines because, again, I'm talking high level. I'm not going to go down into treatments, but not to say that that's not important and really will be one of the key things for the future as well. So I want to, because we work in public health, I want to talk about the importance of, I guess, non-pharmaceutical interventions. And we can divide them into three categories again: individuals, so hand hygiene, respiratory hygiene, staying at home when unwell; community, physical distancing, closures; and environmental surface cleaning. And again, some of you will remember early on in the pandemic, we thought it was all from formats was a big transmission pathway. Eventually we learned it was airborne, but everyone was cleaning everything. And I'm sure India was the same. In Australia, people were like cleaning pizza boxes, you know, for some reason everything was fearful. Everyone lived in fear. And of course, new diseases comes with fear, and we learned a lot about the risk communication and social science aspects of managing pandemics. And I'm not going to talk about that. I do a little bit of work on that, but that's not my area of main expertise. I'm not going to talk about social sciences to manage pandemics, but we can definitely have a conversation. And I guess just thinking about the principles of how this works and why we do it, because we were sharing some examples about the focus on primary care in a country like Australia, where everything is at a primary care level, and their hospital capacities are much smaller than what I would say over here. And this is a nice graph that explains, because this red line, some of you might have seen, was the health service capacity. And the idea of doing, I guess, lockdowns and closures and social distancing, because if COVID had spread, this is how the graph would be. But by having lockdowns, social distancing, we were trying to flatten the curve. Many of you might remember the talk about flattening the curve, to really get to reducing and getting the burden down to a level where your health system is not overwhelmed. And in India, in the Delta outbreak, many of you would have been working, the health system got overwhelmed. Same in Australia, because Delta, compared to the other strains, was a lot more higher, had a lot more burden on the severe cases compared to the earlier infections, or Omicron, which were this thing. It's a really important intervention that we didn't know, and there was some data and evidence from the 1918 Spanish flu times that people were referring to. Influenza pandemic modelers had done some modeling around that, but we really didn't have experience of dealing with lockdowns and everything, as I talked about. And there were lots of lessons learned, but there were lots of challenges as well. So, you know, the COVID restrictions, the early shutdowns and slow lifting really enabled that flattening of the curve. And combined with public health response and contact tracing, it really kept down. So in Australia, in the early days, they were able to eliminate COVID because they're, again, an island country. They locked down all their borders. Everything was locked down. We all went into 6 weeks of lockdown period early on. I think it was in April 2020 when they were so nervous about getting cases in Australia. And they kept it locked down. And I think that helped. Southeast Asian countries did tremendously well. And because they had amazing knowledge, corporate knowledge, as we say, from responding to SARS pandemic, and they were able to eliminate. So they kept the lockdown, everything. People were very law-abiding in some countries, in Korea, in Vietnam. So when the government said everyone needs to stay at home, people stayed at home, and it served them well. And so there were lots of lessons learned. And I'm happy to share the slides if people want to look at references. I won't talk about each individual paper. Whereas in Australia, we were really struggling with, like, I got a call one day from a journalist, and it was my first time ever writing an opinion piece, and I'm like, I don't know who am I to write an opinion piece for the whole country about how long we're going to be in lockdown. But people were frantic, and they wanted to hear from academic experts, and those of you who want to go and work in research or academics, I encourage you to think about these things in your voice, to share those experiences, to help public understand. I think as academics, we have a responsibility to share with the public, to get in front of the media. I did so much media along with other colleagues of mine in the pandemic because people wanted to hear from experts who were independent outside of the government and help close this knowledge gap across the two domains of what is happening, why does it matter, and personal stories. I was equally scared. I was working on the pandemic, but I was also equally scared. My own parents were in Delhi, and Australia had locked borders. I didn't know when I would see them next, or if they got sick or I got sick, what would happen. And I think people understand and relate with that. So I encourage you to think about where your voice lies with this in the future if we were in this situation, of how you can use your knowledge and your expertise and also communicate with the public, not to just keep it within the rooms of where decisions are being made. And I wanted to again talk about then the impact of these lockdowns on COVID. We've talked about it, it slowed down the curve, but we had an unexpected consequence which we did not know about. I think everybody was blindsided by this. And this is the World Health Organization, WHO, did these pulse surveys, they called them, regular pulse. They were essentially like the pulse. They were trying to get a sense of where the thing is. And you can see over here, all essential health services in mid-2020 had partial disruption. So the red is basically the level of disruption, percentage of countries reporting disruption to 25 racer services. And you can see over there, even routine immunization had 15%, which means why we're seeing partly all of the measles and the diphtheria and the polio around the world. We've never really been able to catch up on much of that as well. But you can see other things as well that were dental services, family planning and contraception. Everything was getting disrupted. Antenatal care, one of the big ones, implementation of seasonal malaria chemo prevention. So lots of services that many of you working in community medicine would have to take on and manage as well would get interrupted. As I talked about earlier, even with that movie as an example, really, we didn't expect some of this. And this particular paper that we wrote with some colleagues from Africa, again, talked about these early ideas of what the Western countries were doing with lockdowns. Was that the right approach for low and middle income countries, where people have to move miles very quickly? Should there have been a different approach? And of course, even in Australia, in settings like Sydney, we had very much disparity, because what happens through that process is the inequity grows. Because those who can stay at home and live nicely can, but it's people who are living in poorer conditions or who are well-to-do are the ones who will get impacted much more greatly. As you know, inequity, these things widen the inequity. So even in settings like Sydney, we were seeing Western Sydney is where it's the largest social demographic geographical representation. It's a very large area, it's high density, and has the largest population of migrant populations, first generations to second generations to third generation. It's got most, I guess, Asians, South Asians, Indians, Southeast Asians, Middle Eastern, all of those populations. And some are well educated, but some are not. Some are lower socioeconomic status. And that's where we saw the massive inequity. There were harsher lockdowns, but those were the populations who were also working in jobs of stocking warehouses with groceries and food markets and everything. So those people were still mixing even when there was lockdowns. And so then they started putting harder lockdowns, and then there were greater impacts, but it had no impact on the response itself or the caseload, because it was not necessarily sharp and tailored to what it needed to do, and it didn't provide the support system that was needed for those populations as well. So moving on from PHS, and I just wanted to highlight this particular new decision framework that got launched by the WHO last year, at the end of last year. And it's really thinking about public health and social measures in the future of when it happens, what are the decision points that we need to think about? How do we navigate through ethics, through target populations, through managing what kind of restrictions, what are the decision aids and navigation? So a really good source for future health emergencies. I want to talk about public health responses, and this is particularly for colleagues who are working on the new multi-source surveillance that is getting rolled out in India. And again, it's the way we think about surveillance, COVID-19 surveillance. This is a really nice diagram from New Zealand. And you can see here, this is Australian data. In Australia, we had different forms of surveillance. So flu tracking is a system that looked at influenza-like illness at a community level. You had a system that was looking at sentinel surveillance, so collecting data from primary care and hospitals. And then you've got your severe acute respiratory infections that might be showing your death. And really just shows the tip of the epidemiological triad and where the different burden of disease is. And you want to combine that with contact tracing. I'm not going to go through what details of contact tracing are. You all know the principles of contact tracing. You do it for your diseases, things like tuberculosis almost every day, but also STIs and other epidemic-prone diseases, but really forms the core of thing. But I guess what was the most amazing thing we saw, and perhaps overrated, was this idea of using digital apps for contact tracing. You've got India that did that, you've got Singapore, Korea, lots of Southeast Asian countries, Australia tried to do that. And did it work? I'm not sure, because ultimately, we were all very positive. I personally was very excited and pro using digital apps. But what we really found was that contact tracing still required people and experts in public health to do the work, because a digital app is not going to actually solve the problem. So in Australia, they had an app that was rolled out, and what they found was that the app only enabled finding 2 extra contacts compared to traditional ways of doing contact tracing. Because the skill of contact tracing is in breaking chains of transmission by having people's trust to tell them where they have been. And that an app couldn't do. It actually relied on good interviewer skills and being able to track movement of people and know where the exposure sites are, still do it manually. And these 2 studies, two of my colleagues here did it from the Southeast Asia WHO region, and so they did performance and utility of contact tracing, and what they found was that it was only useful for certain parts of the pandemic. And again, thinking about, I talked about Tonga earlier, small country. The whole country, yes, it's a small population, but they also only have 2 public health doctors at any given time because it's a small country. But suddenly when they had Omicron, they were having to contact trace everyone. Is it worth, if there's asymptomatic transmission and it's already spread to somebody before you can pick it up, it's probably not worth doing contact tracing. And this particular study, one of my postdocs led, was really inspired by this experience in Papua New Guinea when I went for 3 months for contact tracing. And you can see over here the team really sitting down late at night trying to do contact tracing, and they sent me a photo. Because what we were finding was there was this, again, pressure to do contact tracing and isolate and quarantine everyone. Remember, we were doing that 2 weeks quarantine at the start of the pandemic. So once you were exposed, you were in another room. But in places where you have multi-generational households, and so you have 4 families or 10 people living in a 2-bedroom apartment, it's almost impossible to isolate and quarantine yourself. So what is the best use? And so this particular study, what we did was essentially surveyed and interviewed people from across the Indo-Pacific region of what their experience was on implementing contact tracing guidelines. So WHO, governments, they were all giving guidance and documents, but actually implementation of those was not really effective. And so what it meant was it was leading to wastage of public health resources. Not to say that contact tracing is not important, but both of these studies really highlight that the context in which you are implementing contact tracing guidelines and when to do how much contact tracing, perhaps it's about tailoring down to the high-risk groups. So really identifying pregnant women, elderly in the family, but not really worrying about every single person who might have been exposed. And it comes down to the disease and the pathogen of concern as well. And again, this was again part of the Papua New Guinean response, where we were trying to, because in PNG, many of you know, it's a very weak health system. They are a low-income country, not many resources, and all of their doctors were really afraid, and they have a small workforce. So here we're training the military staff, the PNG Defense Force, to supplement and surge their health workforce to support contact tracing efforts as well. But I guess on the surveillance side, the other thing that came into play was the idea of using rapid diagnostic tests for COVID-19. And really, I don't think before COVID-19 anyone thought that we could use these lateral flow tests for early detection. I know there are tests for lots of other diseases like cholera or dengue and leptospirosis, you do ELISAs, but we've never really, and we use them often for things like filariasis, you might use them. Those of you who work on elephantiasis or filariasis will know the lateral flow tests. But before COVID-19, we didn't really use them for epidemic responses, and we definitely didn't use them for clinical management of patients. And I think COVID has really showed us that you can use it. COVID was exemplary in the way that we were able to come up with a PCR test within 3 weeks of a new virus being detected. But it also led to bottlenecks of how people were getting tested and lots of delays in testing and response. And RDTs, I'm a big fan. I think they should be used more for surveillance purposes, but how we integrate it into surveillance is really hard. And that's some of the work that I'll mention later that we are doing. But these were some of the innovative tools that I think came as well. And of course, then there was the vaccines. India did an incredible job at rolling out the COVID-19 vaccine. Like, I remember watching, and I'm like, 8 million doses in one day. It was just mind-blowing. You know, in Australia, they were struggling to get out 40,000 doses at the start. So I think, you know, that learning is just incredible what India had at the start. But I really want to talk about, you know, vaccines as a tool. Again, an area that I'm very passionate about, vaccines as a tool for outbreak response and pandemic response. Because, of course, public health is probably, and primary prevention is the best way to do it. But we know when the morbidity is high, mortality is high, it's really difficult. So this is a graph many of you might be familiar with. This particular thing also, the introduction of COVID-19 vaccines introduced this idea of a 100-day mission by the Coalition for Epidemic Preparedness and Innovation, which was part of the COVAX initiative, which tried to bring together key agencies. And I really like this particular graph because what you can see here is that what they're trying to project here, it's a modeling graph, that they're saying that if we have a vaccine at 100 days, this is the cumulative COVID-19, you can essentially prevent these lives in a 100-day mission. So if within 100 days of a new epidemic or new pandemic, you can introduce a vaccine within 100 days, instead of the real graph which you're likely to see, this is the area under the curve that you can prevent the deaths from vaccines, which is phenomenal. I mean, I didn't think, I did my PhD on a pathogen 20 years ago that we still don't have a vaccine for. So I didn't think we would have a COVID-19 vaccine because I was like, oh, I don't know, but we did. And it was exemplary, and not one vaccine, multiple vaccines. Of course, there were lots of challenges. There was the mRNA, there was the COVID Shield, the AstraZeneca vaccine, which had major safety issues later on. But here we are. But what I want to say is that it also exposed deep inequities across countries and within countries. One of my favorite things from a public health point of view was this particular figure, and I'm not sure, again, it's very small, so I'm just going to read it if you haven't seen this particular diagram. It was a document that presented the framework goals and principles for the rollout of COVID-19 vaccine, and this was led by Professor Saad Omar, who's a very, I guess, renowned name in social sciences, originally from Pakistan, based in the US, around thinking about the equity and the ethics of vaccine rollout. And I thought it was a really nice principle because they talked about the overarching goal was that the COVID-19 vaccines must be a global public good. The goal of the vaccines is to contribute significantly to equitable protection and promotion of human well-being amongst all people of the world. And the key principles were human well-being, equal respect, global equity, national equity, reciprocity, and legitimacy. And these were some of the early frameworks that were coming up by WHO around low priority use groups, medium priority use groups, and high priority use groups. And the high priority use groups included older adults, people with immunocompromised diseases, etc. And then you had children as low priority groups. But of course, I don't think that worked well. We know that COVAX really didn't work because many low and middle income countries did not get access to COVID-19 vaccines on time. Ghana was the first country, low-income country, to get a vaccine through the COVAX initiative, which was really designed to support low and middle-income countries around the world to have vaccines. And they had a 66 days delay. I'll never forget that number. 66 days later, compared to the UK when the first COVID-19 vaccine dose was given out. That is a huge number. In 66 days, when you think about that graph of the number of deaths saved, you could have had a massive impact in those countries. We saw all the vaccine hoarding. You all would know about the mRNA vaccine getting hoarded by very much high-income countries and bilaterally buying from pharmaceutical companies not sharing much of that. We had other social inequities. Again, another example from Australia. This is a local example where, we were saying that COVID-19 vaccine data shows the area with highest and lowest vaccination rates in the country. So again, the same groups that were getting the harsher lockdowns were the ones that were not getting vaccines, because early on, the clinics were not open late at nights. So they were all going out to work. They couldn't get the vaccine as easily. So all of these challenges were really, I think, showing where inequity is really, and we didn't think about that. They thought, I think one of the challenges, again, lessons learned when I look back, I think everyone thought we'll make the vaccine and that would be the hardest thing. But actually what we learned was making the vaccine was really tough, but introducing the vaccine and rolling it out was even tougher. Because again, that public health side of how we bring a vaccine, the policy decisions and then the implementation and then the safety surveillance and monitoring of coverage and subnational gaps and inequity was incredibly difficult. And if you don't live in a community where everyone can easily come to the clinic or like routine vaccination where mothers bring their little children, it's very different to getting elders who have a million responsibility or need to go to work or on lockdown to get them to vaccinate is very difficult. But another thing that I want to mention, and I put this one because I'd love to hear from people of what they thought, because a colleague of mine prodded me and reminded me of how this narrative was all getting shaped when COVAX was becoming challenging. And this particular term, some say it's been around for a long time, but I think it's a relatively new concept, the idea of vaccine security, because in my mind, for somebody who grew up here and really went through that, my own personal experience of working in vaccines is because I grew up, one of my dad's friend's daughter had polio, so I was always really interested as a kid in vaccines, and that is what inspired me to go into the field, was because I had seen her have partial paralysis in her legs. I always thought about vaccines as a public good. But what the pandemic, I think, has made us think about vaccines is vaccines has become a tool of vaccine security. There's vaccine nationalism, people were having, and these are again things that my training didn't typically think about. As an epidemiologist or a vaccinologist, I don't think about the politics of how vaccines are distributed. And it goes back to that slide that I started with, because yes, we can put a policy together, but if, when the vaccine is going to be available. But the availability of vaccines in a pandemic is going to be determined by legislation and political policies that public health professionals need to think about. I don't think we can sit and say, my job is to treat the individual and not think about the global picture in which we are operating in, because that has a direct impact. And this was obviously a major story where AstraZeneca vaccine, the Meru Sheel vaccine, was getting made at the Serum Institute of India, which was an incredible endeavor. It's the vaccine that saved millions of lives in the world. And yet at one point, there was a ban, I guess, on exportation of materials that would allow for this vaccine and for the vaccine to get exported. So this idea of, each country to have enough of that. And that has also led to I guess I'll come to that in a minute about this idea of expanding vaccine manufacturing in low and middle income countries. And of course, India is at the forefront of it. It's got the Serum Institute of India, it's got the Bharat Biotech, it's got other companies that are emerging. I think there's another new one that I'm forgetting the name of. So there's a few very big emerging plants in India as well. So we look at a time machine and think about where we are at now with pandemic preparedness. We've got the pandemic agreement that I mentioned. The IHR failed us in many ways. And this is a new agreement that got endorsed by the World Health Assembly. Many of you would have heard the news in May last year. After 2+ years of negotiating through the intergovernmental body convened by the WHO, it's a framework that helps countries to prevent, prepare for, and respond to future pandemics. It's legally binding. So they've tightened the language. It also, interestingly, now has language and areas to think about things like travel restrictions. Earlier versions of IHR said no travel restrictions, et cetera, But now we know that travel restrictions work as a public health and social measure. So we have to accept that, but we have to think about in which context and what are the implications on society and economics and trade, because we know that the trade really got disrupted as well. It covers lots of different topics. I'm not going to talk about it, but if anybody is interested, they can go and have, if again you're interested in emergencies, if you're interested in public health responses to emergencies, it is a document that you should be well familiar with, because it also talks about the principles of risk assessment as from an epidemiological standpoint, and what is the risk of the disease spreading locally, what is the medium risk of spreading nationally, so subnationally, nationally, and internationally. And when we talk about the Nipah example I was giving, anyone sitting in an office in a Department of Health or in a WHO office will essentially be using those principles to assess the risk of local spread, national spread, and international spread. So I highly encourage people to look at it. But then there's the implementation, which is always the challenging aspect. So it was passed a year ago, and currently they're looking at, how are we going to implement the pandemic agreement. There's an idea that there'll be a conference of parties, so COP, that will essentially serve as a governing body. And then each country is encouraged to consider ratification of the pandemic agreement and really support the implementation. And the WHO's job is to, serve as a technical advisor and facilitate this, but ultimately it's member states. It's all of you to encourage and lobby to the government to ensure that the IHR is implemented at a national level and, contributes to international guidance in the same way as well. This, I think, is a really important initiative which all of us who work in this space are quite nervous about. And this is the annex on pathogen access and benefit sharing, because we know this is where some of the challenges were early on. And this is meant to get endorsed in May this year at the World Health Assembly, but the negotiations are not looking as optimistic at the moment. And this particular annex is all around the idea of the sharing of pathogens in case of a new emerging pathogen. And again, goes back to some of that surveillance conversations we were having about how much screening should you do and what happens with that. And the idea is, well, if a country from the global south or low and middle income country shares pathogens or shares the sequence, they should be entitled to early interventions and reagents and treatments and vaccines and PCR tests, all of the things that go with it in return for sharing that. And that's where these things are coming into play. We know there were some unfortunate instances. For example, the Omicron that was detected later in the pandemic in December 2021. South Africa reported a new strain, the Omicron, and the whole world went about putting travel bans against it. That was such an inappropriate action because they were doing the best thing to alert the world that there's a new strain, but they got slammed with travel bans that were discriminatory. And this happened extensively, including in Australia. Australia had a specific travel ban against India in the Delta side, because there was high morbidity and there was a lot of pushback and a lot of criticism from local experts around that. So this particular annex is again trying to prevent some of those inappropriate actions when countries are trying to do the right thing, and also give them early access to, I guess, things like vaccines and treatments. But it's under negotiation and they're not able to reach a consensus. So lots of people fear who work in this space of global health law that it's not going to go through, but something for all of us to keep in mind and advocate for the right thing to do. And of course, we might think that it's beyond our everyday remit, but we all have our voice, and that's why I'm sharing these examples, because it's things and conversations when we talk about that influence this stuff as well. There are other things that have happened, like this new particular document around architecture for health emergency prevention, preparedness and response and resilience. It talks about principles of how we run pandemic and the multi-sectoral responses as well. And so one of the core concepts of that is the collaborative surveillance idea, which is really multi-source surveillance that we were talking about earlier. And it talks about how different how we need different types of data for good detection of pathogens. So from the community level to the hospital level, but you also need to bring in your border control or your movement data. So many of you would have seen data from movement tracking devices or phones and Facebook data, metadata, that how much are people moving across places, and that becomes really, really important as well. And the idea is to bring in different collaborations in that as well. I want to now briefly talk about measles, because I know measles is an issue of local concern, but it's also something that I'm working a lot on, because I think measles is a really amazing example. Many of you will know that measles is also called a tracer disease. It's obviously caused by the measles virus, a paramyxovirus virus. It's highly contagious. Its nascent reproductive number is 18 to 20 in an unimmunized population. In many settings, in places like India, Australia, we just don't see that level of transmissibility because the vaccination rate is relatively high. But then there will be pockets where there'll be much more suboptimal vaccination and the disease will spread faster. To all of you, I'm not going to go through these symptoms. You all know the disease really well. But I guess it's a reminder that because it's so transmissible, the WHO recommends 2 doses of measles vaccination at a coverage of greater than 95%. And we know that that is really challenging in many settings at the moment, both from an access barrier, but also increasing misinformation, disinformation, hesitancy, but also because measles is often given later in life. So it's easier in that first 3 months when a baby is born, relatively, and then we see this idea of a dropout. I think in India it's still at 9 months, the first dose. Correct, whereas in Australia it's at 12 months and 18 months, whereas India it's 9 and 15 months. In endemic settings, you give the vaccine earlier. But even by the time you get to 15 months, we know that there's a loss to follow up or drop out of children as well. But all regions of WHO, so all countries, have an agenda for measles elimination. And it is possible. I think measles elimination in constrained geographical areas is possible. It may not be possible to eradicate like we did with smallpox. Measles case distribution, being an epidemiologist, when I'm talking about a disease, I always have to start with the epidemic curve. Okay, I have about 5 minutes, so I'm going to start wrapping up. I have a few more slides and I've spent too much time. But you can see over here how we're starting to really see this increase in measles case distribution globally as well. So some of the work that we're trying to do is use measles as a model for pandemic preparedness. And really, lots of my colleagues don't always agree to that approach, but I personally think measles can really serve as an example, because you can learn from controlling the outbreak at a local level. And we know that outbreaks begin and end in communities. So if you can control an outbreak at a local level, we can prevent it from getting an epidemic, and we can learn a lot from it. And this is a really nice modeling paper, which one of my colleagues from London worked on, and he basically talks about it, is that controlling minor outbreaks is necessary to prepare for major pandemics. And he's using an influenza example where you essentially are showing that if you can control your outbreak at a local level, it can prevent a pandemic, and combined with the public health response. And what we're trying to do in this particular thing, many of you may not know about that, is that we are about to get a rapid diagnostic test for measles in the market, hopefully in the next 6 months to 12 months. And so similar to COVID-19, we're trying to combine that with epidemiological surveillance and outbreak response in Laos and Philippines, and seeing if early detection of measles can help us curtail some of that as well. Pandemic vaccines are going to be a major area of work. I've already talked about this. I'm not going to go into it, and I'll share slides. But again, something for us to think about is the idea of immunization inequity. I think we've all learned that countries can now roll out vaccines very quickly in the pandemic. But where there's inequity, target groups that get left behind, be it from social geography perspective or for certain high-risk groups, is really important for us to think about. And I just want to quickly put in a plug of about thinking about One Health in the context, which is really critical part of the pandemic agreement and pandemic response. Japanese encephalitis is a really good example. And I guess, this is an old graph. India obviously has vaccination at a subnational level. It's not a national program, but there are countries with national programs, and it's a pathogen against which the vaccine has shown to work really well at curtailing the disease. But I just want to mention this example of One Health, that post-pandemic that Australia used as a test case, because Australia never used to have endemic Japanese encephalitis. And it was a disease that got introduced from Papua New Guinea, and they didn't detect it early, and they detected a death. And they first thought it was a COVID-19 encephalitis death. Ended up being a Japanese encephalitis case. That person had not traveled. Actually, it was a family friend of mine who was that person, their father. And they looked back retrospectively, and basically the disease had been circulating. They did not have good sentinel animal surveillance, so it got missed early on. And now we've got endemic transmission. They've had lots of challenges. You can see over here cases. This is a work that one of my students led Zoe Baldwin, doing a serological survey, and we found deep surveillance. So it's again thinking about, what is the role of One Health in that pandemics as well. Avian influenza is another example. I know we're out of time, so I won't go through it, but just something for us to think about. We need to be prepared for this. Bird flu is real. It's affecting many animal populations. We haven't seen many human cases, but it's still a reality possible. Things that I haven't gone into today is like health workforce, i.e. all of you and your trainees, ecology and environment, research and innovation. But these are all important critical parts that we want to think about. And I guess in summary, I'll say pandemic responses are complex. They require agility and multi-stakeholder collaboration. We need a support for pandemic agreement, but we also need, I guess, good pandemic science and grassroots voices to do the right public health practice, the right medicine, including thinking about all of the aspects of surveillance, of vaccines, of treatment and clinical care as well. And that's it from me, and thank you for listening. I know we're out of time, so I welcome questions after this. Thank you.
Thank you so much, ma'am, for that insightful lecture. And now we'll move to the question and answer session for this. Okay, sir. Okay, sir. So thank you, everyone. I would like to invite Dr. Somdata Patra, ma'am, for a brief vote of thanks.
Yeah. So first of all, I would like to thank our distinguished guest speaker, Professor Meru Sheel, for such an engaging and thought-provoking lecture. Ma'am, we are truly grateful that you took time to share your knowledge and experience with us. Our appreciation and thanks to respected Principal Professor Dheeraj Shah sir for his constant encouragement and support for academic activities like this. I would like to acknowledge the support of administrative colleagues, especially Assistant Registrar Ms. Rupinder Kaur and Deputy Registrar Mr. Rajesh Kumarji for helping with the arrangements. Our thanks to Dr. Manish Gupta, Lecture Theatre in Charge, along with Mr. Alekji, and all the LT staffs for ensuring that all the logistics were taken care of. We are grateful to the photographer, Mr. Hariprasadji, for covering the event and capturing these moments. I would also like to recognize and thank Dr. Shatendra Singh sir, the Member Secretary of International Academic Research Collaboration Cell, and the efforts of Professor Arun Kumar Sharma sir, HOD Community Medicine, for organizing this important session. My thanks to all the heads of the departments, all the faculty members and residents who joined us despite their busy schedule. Finally, a special thanks for all the teaching and the non-teaching staffs of Department of Community Medicine, especially Dr. Prabha and Dr. Aniket, for all the helps in making this program run smoothly. Also thanks to the residents and the staffs of Community Medicine Department who could not be here because they have to run the health training centers in the community. And I hope that today's discussion reminds us that equity and health system strengthening, they are the key for preparation of future pandemics. Thank you all for your presence and participation. Thank you.
Thank you, ma'am. I request members of the organizing committee, Principal Sir, Dr. Meru ma'am, to please stay back for a group picture.